We all might know that over the last years there has been a lot of attention for maternal health, to improve maternal health, to reduce maternal mortality. World leaders have been busy with it, and what we see is that over here maternal mortality is declining over the last years. However, what you see here on this map is that especially the red countries, most low-income countries, low-resource settings, are far behind. The goal of the MDG 5 to reduce maternal mortality by 3/4 by 2015, it will never be met in those countries. So what did the WHO do to reach these targets? They said you must improve accessibility, availability, and the quality of emergency obstetric care. And one of the things they said to monitor the progress and to monitor the availability of this emergency obstetric care is to monitor the cesarean section rate. So what they said if your cesarean section rate of a country is between 5 and 15%, your availability is all right. Meaning that if you are below, which most low resource settings are, they say you must do more cesarean sections. And if you are above the 15%, you're performing unnecessary cesarean sections. However, more and more data is coming available, telling us that in those countries, cesarean section rate is rising. However, also unnecessary cesarean sections are performed. And sometimes there has been a lot of big research has been done showing that in all Sub-Saharan Africa, the cesarean section rate is rising. Up to now, it did not improve maternal and fetal outcome because often it's performed too late or with the wrong indication. And on the other hand, we have a lot of women, they don't have access to this potential life-saving intervention. So what is the cesarean section rate going to tell you? It's not going to tell you anything about the indication for the cesarean section or the quality. In a rural hospital in Tanzania, a prospective study has been performed to assess the quality of obstetric care in all maternal death cases and maternal near-miss cases. And maternal near-miss case is more and more used to study the quality of care. Those are mothers who nearly died but survived the complication during pregnancy or delivery. And what we found in this study is that a lot of women who were included in the studies were delivered by cesarean sections, and that's why we decided to audit the indications for these operations. The study was performed in Haydom Lutheran Hospital. It's a rural Tanzania hospital, 400 beds, referral hospital. We have 5,000 delivery each year. In Tanzania, I think at the moment 50% of the deliveries is attended by a skilled health provider. The other 50% is delivering at home. And in this hospital there was a vacuum delivery rate of 0.2% and the cesarean section rate of 16%, and it's rising over the last couple of years. In our study, or in the intervention study, 248 cases were included, of which were 32 maternal deaths, and 90 cases were delivered by cesarean section. We had to exclude 8 cases because the cesarean section was performed at another health facility, so we could not audit the indication. So we audited a team of Tanzanian and both Dutch medical doctors audited the indication independently. And when we didn't agree with each other, an expert panel of both Tanzania and Dutch obstetricians were asked for their opinion. What you see here is the clinical characters of our patients. We had 20 nulliparas in our group. 40% of the women was delivered at least once by a cesarean section before. 25% was premature. We had 6 maternal deaths, and also the fetal outcome I think is quite striking, with 80% fresh stillbirth, macerated stillbirth, and also quite a couple of neonatal deaths. This is our top 5 indication that was listed, with on number 1 antepartum hemorrhage, which were mostly placenta previa, fetal distress, quite a high number of uterine ruptures, obstructed labor, and also ladies with a previous cesarean section. These are the results of the audit, and what you see here in green on the left are the cases, 36 cases, where the audit found that it was a justified cesarean section and there was no delay in performing any key evidence-based intervention. So there was no delay in rupturing membranes, monitoring the mother. And the indications that were mostly antepartum hemorrhage and uterine ruptures, and then both the ladies were coming in severely bleeding in shock, went actually straight to the theater. Also fetal distress, and then there was a significant symptoms of fetal distress. Also we had 4 cases with ladies, they had 2 or more previous cesarean sections, so obviously they delivered again by cesarean section. And 1 lady came in also with severe signs of impending uterine rupture. Next group is quite interesting, is that those ladies had a justified cesarean section at the moment the indication was there. However, during the process, there was a significant delay in performing key-based, evidence-based interventions. So we had 6 patients with fetal distress, 5 cases with uterine ruptures, and 3 cases with obstructed labor. And in all these cases, at the moment the cesarean section was performed, it was correct. However, the membranes were ruptured way too late. The oxytocin was not started or started too late. The cesarean section was performed too late. So you can imagine that obviously there is fetal distress if you leave the woman 5 hours in the 2nd stage, or if you don't rupture the membrane, obstructed labor will occur, uterine rupture will occur in your hospital. The last group, they had an unjustified cesarean section. In 6 cases, the file noted obstructed labor. However, the membranes were still intact, or the action line was not even crossed in the partograph. We had 3 cases with a previous cesarean section, and the case notes stated scar pain. However, there was no fetal distress. The mother was in a good condition. We had 2 intrauterine fetal deaths, and there was no destructive labor performed, like Thomas Raas already told us. So I think this is a quite interesting case. In 10%, we could not audit the indication because the case notes were insufficient to audit the indication. Then, why is it so important that we don't perform these unnecessary cesarean sections? Why are everybody's more and more data coming available? The conditions in the theater over there is completely different than in our countries over here. There are much higher risk of infection. In our cohort, 12 patients developed sepsis after the cesarean section, and 1 lady even died. There are much higher risk of hysterectomy, of bleeding, of damage to the other organs, the bladder, the bowel. Also, future pregnancies, they are at risk of uterine rupture, placenta previa, placenta accreta. I think we all know the risks. So what should we do? This lady must do all her future deliveries in hospital, but we all know that some of the ladies have to walk 2 days to find the hospital. So what are you going to tell her? When labor pains start, you must come. She will be too late, obviously. So then you say, come 1 month before your due date. We don't know the due date in those countries. So some of the women stay 2 months in hospital waiting for their labor. But when they have 5 other children at home, they won't come. If they have to harvest, they won't come. If their first baby died because you failed to give her quality of care, she obviously won't come back to your hospital. And of course, the financial burden, both for the patient and the hospital, is much more expensive to deliver by a cesarean section compared to a vaginal delivery. And then next slide, why is it happening? I think we can quite, does anybody know how many nurses will take of all these 40 women on night? 1. So you have 40 pregnant ladies, women who delivered. We have a preeclamptic patient, 1 is bleeding. You can, like, we audited the cases, but we don't know what happened at the same time. So we cannot blame the nurse for not rupturing the membranes if we don't know if there was also a preeclamptic patient or a uterine rupture that came in at the same moment. There's really a lack of human resources, which is, I think, the biggest problem and the cause why it's happening. Over here you see the partograph, and it's one of the rare cases that it was filled in completely. I think they must be taught how to fill it in, what to do when you cross the action line. Also the vacuum delivery rate. You can't blame them that they're not performing if they don't know how to do it. Next presentation will go on with that. 2 other studies have been performed in similar settings in rural hospitals in Tanzania, and they found actually quite the same numbers, with 26% of unjustified cesarean sections, and one even found 44% of unjustified cesarean sections. It's important to keep in mind those are in the regular population, and we included maternal near misses and maternal deaths. So, of course, our leading indication was antepartum hemorrhage. We had a lot of uterine ruptures. In the regular population, number 1 and 2 is obstructed labor and fetal distress. So just to conclude, in our population with a severe maternal outcome, we found that 20% had an unnecessary cesarean section, and 25% there was a significant delay in the using of evidence-based interventions, which could have either improved maternal or fetal outcome, or even prevented the cesarean section. So I think cesarean section rate is not a good tool to monitor quality of care. I think audit is. Research has shown that with audit you can reduce postpartum hemorrhages, you can reduce uterine rupture, so you can really improve your maternal care. Thank you.
Thank you very much, Steffie, for this good presentation and keeping time. So we have some time for questions. Do we still? I think we do that without a microphone, or otherwise, because it is with a Who has a question? Completely at the back there. Okay. Yes, please.
Yeah, thank you for the nice research thing, and also for nice presentation. I would disagree on your conclusion, because you mentioned that cesarean section rate is not a measuring tool. I mean, I think the way you measure has some problems. This is the way I see it. Meaning, you are not clear with the nominator and denominator. Because these hospitals, even if they have 40% cesarean section rate, because the selection of the patients who are coming to this hospital, there might be some peripheral hospitals who deal with the normal deliveries and send all the complicated patients to this hospital. And obviously, you desire no wonder. So I think we have to really work on this, so that you have the denominator first. Out of how many women, how many are delivering by cesarean section. But your denominator is just the hospital admitted patient, which is not right. Those who deliver in other places, with normal delivery should be considered as denominators. In that case, your figure might be 15. So when you don't have, the proper, when you are not using the proper measuring tool, you cannot blame the tool.
Yeah, that's true. But like what they stated is that it should be on a national level, so not on a hospital, because of course it differs between the hospitals. If you have a rural hospital or a university hospital or a private clinic, of course your rate should differ, and that should be the case, I think.
I have one question.
Yeah.
Actually, maybe you don't know it more than that, or we'll get somebody else in the room who knows the answer on the question.
Yeah.
The question is, who were performing the cesarean sections?
Yeah, we checked. We had a look at that as well, and we found that we had a look at who did the indication, who supervised the indication. Was the indication by phone? Was it in person? What time was the indication? Was it at night or was it during the day? But this group was too small to find really significant difference. So.
I can ask Dr. Nuas, because he knows. At the moment when you're in Haydom and you're at nighttime and you need a cesarean section, who's doing that? Who are on call.
Yeah.
We didn't have specialists in dementia years at Haydom.
Yeah.
And there was no clinical officer who was deciding at any time material in Haydom for the cesarean section. So mainly the AMOs or registrars on call.
Yeah. Mostly AMOs and medical students as well, like Tanzanian medical students, and Yeah, we had like 3 cases that were done by obstetricians.
It was probably, this was 2009 through
11.
2011. So the medical students or interns started, I think, very late in 2010.
This time, most of the time,
So mainly 2011.
so what happened now, there's a change, so there's a development now in Haydom. I was just there together with Nuas. Now there is a specialist in gynecology who's working there. But of course he's on his own, so most of the time when the cesarean sections are needed, he's
Yeah.
not there. That's something to keep in mind. So I was there for 3 weeks and I saw that in the 3 weeks, most of the cesarean sections were done by medical students. They're in their internships, so during the course. That's important to know that in this situation.
But it's important that the Tanzanian medical students, not the Dutch medical students. Yeah.
But
Luckily enough, we're not Dutch because the Tanzanians, they are trained to do that. And here we're not trained anymore to do that. And it's not because that's a mistake, but otherwise, as I explained already in this big hospital, the doctors would be completely exhausted. There's so many severe infections every night. It's not possible without the help of the interns.
yeah, so I think when we say medical student, we might have different impressions versus intern. Intern is a qualified, medical student who has been given permission to do practice under supervision, and therefore they're allowed to do some decision of excellence, but implementation is another element. It differs in terms of, the human resource in the respective hospital. So in Haydom, of course, I think we had registrars who are working, but of course at times they're exhausted when interns are making decisions and implementing. So I think it could have been more interesting if you gave like an overview on who makes decisions, not the names, but at least the qualifications. Interns, registered registrar, specialist, or an AMO. Then that gives a bit of, then you can address the issue properly to know, okay, who do you want to train much more? Where's the issue? Where's the problem? And then the other issue which I wanted to ask is, did you compare, the findings in Haydom versus other hospitals of the same settings?
Yeah, that were the 2 last studies, but it's very difficult to compare because, like, before we started it, we wanted to have a list with what are indications, and we tried to find them on hospital level, and they were, during our study, not available. But even to find them on national level, it was not possible. In the end, I found a doctor in Norway who did the same study in a comparable hospital, and he had some list he found at the ministry, but it's not obviously not used in the whole country. And for example, the WHO states fetal distress between a heart rate of 180 and 100, and the most Tanzanian guidelines tell you 160, 120. So it's very difficult to compare because there's no available list with indications. Which malpresentation should be delivered by cesarean section? What is the definition of obstructed labor? But the 2 studies that were done were similar settings, and they found actually quite the same. The delay with rupturing membranes, no oxytocin, and